Open your textbooks to page 17. So, as she said, my name is Mike Mavencamp. I'm an optometrist at West Valley Vision Center. I've been practicing there for about 15 years. This is going to be a kind of interactive type of lecture presentation, as it were. My mother-in-law, who's from Texas, says I talk way too fast. So if I start going at 1,000,000 miles an hour and you want me to slow down, just raise your hand and tell me, all right? If you have questions at any point, please raise your hand or just speak out. I don't care. Pretty informal around here, all right? So with that said, let's get started. All right, so the first thing I'm going to go over is kind of normal versus abnormal vision changes you can expect as we get into the golden years. Golden years, I love that. All right, so you know, many of the vision changes that we experience as we age, while frustrating, are quite normal. That's just part of getting better, smarter, better looking. The first time is nighttime glare, and I get this all the time. Partly because we live in Fairbanks, Alaska, so nighttime glare is 8 months out of the year. So it's something that we guys have to deal with on a regular basis. Another thing that we deal with is difficulty reading in poor lighting conditions. I'm sure we've all kind of gone through that. Thankfully, with the advent of LEDs, we can, you know, crank up those lights, and we've got them stashed all over the place, and you can use those for reading. That helps out a fair bit. Something else that's quite normal is transitioning focus from near to far. You know, if I got my kids in the back here, they can sit there and look at this and look up and see and look back down. It's not a big deal. Whereas for us, it takes this period of time, which is quite frustrating, to allow our eyes to focus and then come back to here. I kind of compare that to, again, if these guys sat in the corner with their legs crossed for 15 to 20 minutes and stood up and walked out, they would be fine. I would be non-ambulatory, right? I would be in the corner. So, watery eyes. This is something that's very common. I'm sure most of us here has experienced it, both because of the aging process and because of the environment we live in. We live in Fairbanks, Alaska. It is an Arctic desert. It is very dry. It's very arid. So that is going to inherently cause more problems for us. And there's some tips and tricks we can talk about how to kind of address that, especially this summer with all the smoke and the irritants in the air. That's just something we have to deal with. And floaters. And again, this is an exhaustive list. This isn't any and everything that we could possibly deal with, but this is kind of a short list of what I see on a very regular basis. Yes, ma'am?
I thought floaters were a problem.
Floaters, there's different types of floaters, and we'll address that later on. There's normal floaters that we all get, and then there's abnormal floaters, and we'll kind of address that as the lecture goes on, and there's certain types of floaters that are a problem, or can be potentially a problem. Some of the vision changes we experience as we age that are abnormal. Diplopia, double vision. This is abnormal, all right? If you see two of something, as much as I love seeing my wife, if I see two of her, that's trouble, right? You need to get checked out right away. Central vision distortion. If you're looking at something, and I always tell people, look at door frames. Generally speaking, depending on your contractor, but generally speaking, you should look at a door frame and it should be relatively straight. If you see a wiggle in it, if you see any kind of distortion to it, you need to go get that checked out. You need to get seen. Intermittent light flashes. Again, this is going to feed into our floaters down the road, but intermittent light flashes can often be a problem for us. And sometimes it's not that they're a problem, it's that they potentially are a problem. So we need to get it looked at. You can't just look in your eye and say, oh, those light flashes are nothing. You need somebody else to look in there and determine, are these just a normal part of the aging process, or is this something that's more concerning, okay? And I put et cetera because there's a lot of other stuff, but those are the big ones. Anything? Good. All right, some kind of housekeeping stuff we're going to go over is the anatomy of the eye. And these guys were nice enough to supply me with this fancy thing. So we're going to start on the anterior, the front surface of the eye. There's the cornea, which is the clear front membrane of the eye. And that's the first thing that when light comes in these parallel rays, it strikes that cornea and starts to diffract or bend. The focusing part of the visual pathway begins, okay? And just to the side of the cornea, you've got the conjunctiva. We've all heard of conjunctivitis. There's different types of pink eye. We won't get into that. But the conjunctiva is a clear membrane that covers the sclera. Now, the sclera is the white part of the eye that we can all see. On top of that sclera is a clear membrane called the conjunctiva. That conjunctiva is continuous as it gets down in the sulcus and then comes around. If you pull and look at the back of your eyelid, that conjunctiva comes up to the back of the eyelid as well. There's just two different types. And then behind that, we've got the iris, the colored part of the eye. Center of the iris is the pupil. Then we've got the ciliary body, which is smooth muscle. We'll talk about that a little bit later. That does two things. One, it's a muscle which allows for constriction and expansion of the zonules, which allows the lens to change shape. That's how we go from our focusing from near to far. And also, it produces fluid, and that fluid will travel between the lens and the iris through the pupil and out through what's called Schlemm's canal right here. And that fluid allows for this to maintain its shape. And we'll talk about that with glaucoma in a little bit. So that light comes in, it's cruising along, it hits this, it starts to get bent, and it hits the crystalline lens, and it gets bent some more. And then it, hopefully, in an eye that doesn't need glasses, will focus back at the macula. And then from the macula, it travels via the nerve fiber layer, the ganglion cell layer, down to the optic nerve. From the optic nerve, it shoots back to the visual pathway to the back of our brain and allows us to see. The retina is just a thin membrane that contains the photoreceptors. There's 10 layers to it at the back of the eye. Choroid's the vasculature that supports all the retina. And the sclera is the outer tough connective tissue. Does that all make sense? We're all tracking? Good. All right, so here's the actual visual pathway. And this is just if someone just kind of took someone just took a saw and just kind of cut my head open. Like I said, light comes in. This one's got it doing the temporal and nasal, but basically it's a macula. It goes from the nerve. From the nerve, it goes back to the chiasm where it splits. Then it moves down to the optic tract, through the lateral geniculate nuclei, through the optic radiations, and then ends up way back here at the primary visual cortex, the occipital lobe. The reason I show you this is just to give you an understanding of that it's a fairly in-depth process to go from out here back to here to see. So there's a lot of things that can occur in that pathway which can cause vision problems for us. It's not always eyes, right? A lot of brain issues, microstrokes, all kinds of tumors, that kind of fun stuff we get to deal with. Those can all cause problems back in here which can affect our vision. I'm not going to talk about that today, but just keep in mind that's part of this. All right? All right, so I'm going to start at the front of the eye. Again, if I go back to here, we're starting at the cornea right here. So in the cornea, one of the things that we see is a steepening in the cornea. This steepening, or this sharpening, changes how light gets bent or refracted, right? Just like a normal lens, if I have a lens that's flat, it doesn't bend light very quickly. If I have a lens that's very steep, it's going to be very strong and bend light very quickly, all right? This can induce refractive changes, most often astigmatism. Now, you hear people talk about the astigmatism, kind of like the gout, right? That's not how it works. Astigmatism is simply one of the types of refractive errors that can occur in our eyes that we put into glasses to allow people to see, all right? So you have people who go along their entire lives and they don't have any problem seeing, they're doing well, they get readers in their 40s and they think everything's good, and then they get into their 50s and they come in here and go, man, I used to be able to see that sign way out there. And I say, I used to be able to dunk a basketball. I couldn't, but I say that because it makes me feel good, right? But no, so, you know, that's one of the reasons we have these refractive changes is because, again, that cornea is changing shape. And it's just like if I had a way, if this lens wasn't hard plastic, if it was pliable, if I could just squeeze it, it's going to change how it bends light. So that's part of those normal changes, and again, that affects our nighttime driving, which, go back to the 8 months here in Fairbanks, it's very common. So these are kind of the things we start to see as people start to notice mainly distance vision blur and mainly in poor lighting conditions, but also just in day-to-day activities, you know, on the computer, going to the movies, watching TV, the little thing at the bottom of the TV, that ticker that goes across here, that's going to all start to become blurry, and oftentimes it's because we're having refractive changes from that cornea changing shape. Gutata, that's just fun to say too. So gutata, so the cornea has these 5 layers to it. I'm going to just go to the front and the back. The front's the epithelium, and there's a middle, and then the back is the endothelium. That endothelium has pumps on it. And those pumps are designed to regulate how much fluid is going into and out of the cornea. You want that cornea to be clear. If it's not, if there's too much fluid in it, it looks kind of steamy. If there's not enough fluid in it, it gets opaque, okay? So those pumps will regulate that. As we age, those pumps will start to break down. As we age, those pumps start to lose their ability to function very well. Now, thankfully, we've got a ton of pumps. We've got extra pumps, right? But still, as we lose those pumps, throughout the day, we go to bed at night, you close your eyes, less oxygen gets to the cornea. That changes effectively the ability of those pumps to function. And so now you get this fluid buildup. So you wake up and your eyes are blurry in the morning for the first half an hour or hour, and you're trying to blink it away, and you're trying to rub it away, which you never rub your eyes, but you're trying to make these, and then slowly throughout the day, the vision gets better. And you go, huh, that's weird, and you move on with your day. Sometimes that's because those pumps just take some time to get fired up throughout the day, to draw all that fluid that's been sitting there overnight out of these eyes. All right? Arcus senilis, that just sounds really bad. It's not. It's very normal. If you ever see anybody, they've got that white ring around what's called the limbus, where the white part of the eye meets the colored part of the eye, the iris. They have this white ring that goes through there. That's just a cholesterol deposition that's very normal. We see it in the aging population. It has to be pretty dense to just notice it in a day-to-day conversation. I see it all the time because I've got a microscope that magnifies things 45 times, so it makes it much more apparent to me, which is why I guess I threw it on the slide, because we almost all have it. However, it's not generally anything to be excited about or scared about. There's a small part of the population, if they see it under, say, 40, under 35, there's a chance for hypercholesterolemia, a high lipid deposition in that cornea, which may be indicative of something happening on a more systemic level, high cholesterol. But in the aging population, it's quite normal. Decreased wound repair. So you get this slower healing of the cornea, and along with that, you get more susceptible to dry eye damage, which we call keratoconjunctivitis sicca, to sound really smart. But what happens is you also get a decrease in tear quality and volume. And again, we live in an Arctic desert, so that makes it even worse. So now this tear film, which should be this nice, thick, robust combination of water and oil that sits in that cornea and protects it, starts to get thin and kind of streaky, and now you've got this exposed front surface of your eye. This cornea gets exposed, and it dries out. And it dries out, and remember, the cornea has more nerves per square millimeter than any other tissue in the body. So it's very sensitive. So it starts to dry out, and now that cornea starts to look like my lips when they get dry. They look cracked. Like your skin when it gets real dry, it looks cracked. And that light, which wants to come in and hit a smooth refractive surface to bend very efficiently, starts to scatter. Okay? And as it scatters, it becomes this positive feedback loop, because now this cornea is exposed to this dryness. So your body says, hey, I'm going to solve this problem. I am going to use a reflex tear from the lacrimal gland to re-moisturize the eye. So it sends tears down. Here's the problem. As those tears are very watery. They're not very oily. So it's kind of like licking my lips when they get dry. What happens, Dr. Teal? They get more dry, right? It's the worst thing in the world. So what happens is you've got these lips that are dry. You lick them, they get more dry, and you get this horrible feedback loop. It just gets worse and worse. The same thing happens in the eyes. Eyes are dry, watery tear comes in, feels good for a second, but it washes all what little oil is there out of there. Eyes are more dry. Reflex tear says, oh, I've got this covered. And then it becomes a process where your eyes are watering. And it's funny, it can be this kind of slow, insidious process, and all of a sudden you walk outside, or you walk in a movie theater, you turn the air conditioning on, or something happens and it just, the faucet turns on, and you just can't help it. And you just, God, my eyes are watering. And I tell patients, well, your eyes are dry. And they go, I need to see somebody else who knows what they're talking about. It's that simple. So, all right, any questions about that? That all make sense? Okay. All right, so now we're going to move kind of to the anterior, the outside of the eye, the adnexa. So dermatochalasis, and that's just that, like it says here, excessive skin on most often the upper, but it can be the lower eyelids. It's caused by loss of elasticity of the connective tissue supporting the structure of the front portion of the eyelid. Basically, you've got this eyelid, and it's got a bunch of muscles and tendons in it that are getting stretched out. And as they get stretched out, they start to come forward and forward and forward and forward. And all of a sudden, you feel like you have to do one of these to have a conversation. Or you go, huh, that looks better. That's crazy. And that's perfectly normal. Where do we intervene? At what point do we decide, hey, we need to do something about this? Usually when the visual field gets affected enough where the superior 35 degrees of visual field is missing because the lids are drooped down that far, okay? So the lids start to get down and get down and get down, and all of a sudden I'm bumping my head and stuff, or I'm feeling like I just can't see, or my quality of life is affected. We run a visual field, we map this out and say, hey, the top 35 degrees of your field are gone. Then we send you down to the oculoplastic surgeon, and they can nip and tuck.
What age, I mean, is average?
You know, what I find is that if there's a family history, then it happens at a younger age. You know, sometimes, oh, my sister has this, my mother has this, more often in women, not always, but more often. My sister has this, my mother has, my grandmother had this, and that tends to happen in the 60s. Outside of that, generally speaking, the 70s. At some point in the 70s is where most women kind of go, hey, this is bothering me. And again, I'm not picking on women. It does happen with men. It just seems to be less often. Yes, sir.
When the eyelid droops, can cause the eyelash to point inward then toward the eyeball.
See, you're getting ahead of me. That's my next slide. Yeah, I'll address that in just a second. That's on the list. Good question, though. Okay, so recap, loss of elasticity. Oh, sorry, my screen keeps going dead here. There we go. Loss of elasticity of the connective tissue, lid starts to droop. So first, there's ectropion. Again, generally caused by the weakening of the muscles and stretching of the tendons that hold the lower eyelid in close apposition to the globe, the eyeball itself, associated with excessive tearing and ocular surface damage. The biggest thing here is that we need that lower lid to sit next to our eyelid to trap the tear film to keep it from just running right out through our nasolacrimal duct or over to our cheek, right? It acts as a sort of dam to kind of keep that when we blink. The tear film actually, when we blink, we don't blink like this. We blink in this very subtle wave. It goes from the outside to the inside. And the reason for that is we have the superior and lower punctum, which drain the eye, okay? So you do this, and it covers the eye with this nice tear film that goes across there. And whatever excess is there, it drains it. Thank you very much. So when all of a sudden that lid starts to roll over and droop on us, you lose that ability. And so that blink isn't nearly as effective. That wave mechanism that should occur isn't nearly as effective. And also, you've got just exposure. I mean, that whole inferior third of that cornea and that conjunctiva is completely exposed to the elements, and that in and of itself causes keratinization and dryness and all kinds of possible problems. So again, this is where oculoplastics come in, and they can pick that back up and tighten it back up. Entropion, like this gentleman asked about right here. So entropion, it's kind of the same thing, again, often caused by the weakening of the muscles and tendons that hold the eyelid in place. Are you guys seeing a pattern here? Weakening of muscles, tendons, ligaments, does that sound? Yeah, okay. Getting old is not for the faint of heart, I'm going to tell you that. Right. Says the 40-year-old in front of the room. It's associated with excessive tearing, pain, and redness. Possible photophobia from eyelashes damaging cornea. So this is worse than the first one. The first one has exposure keratitis that can damage the eye. This one right here has a mechanical structure that's rubbing on that eye. It's got something that's actually abrading that surface, which is bad for a couple reasons. One, it hurts. All right, if I have someone that comes in with something like this and it doesn't hurt them, I'm terrified. That means that that cornea is so shot, those nerves are so dead that that tissue is pretty far gone. So this is terribly irritating. The second thing is anytime you abrade that cornea, remember that epithelium needs to work as it's the gate that keeps bacteria that normally occurs in our eyelashes from entering the cornea itself and causing infections. So if you start to abrade that epithelium, you're poking holes in that gate, that fence, that whatever you want to call it, the defense mechanism. So now this bacteria that floats around your eye that normally can't enter the cornea can get in there. And we've got normal staph bacteria in there, but it can cause some real problems for us. So this is something that, again, we want to take care of sooner rather than later. So those are eyelashes.
Yeah, okay.
Yep, so the lid's actually turned in, and those eyelashes are folded in and then coming back out like this. So every time he blinks, the eye moves when we blink, it rolls back, it's Bell's reflex. So we blink and that eye does this. So you get these eyelashes that are coming in like this, and you're blinking, and it's just rubbing. And even worse, he goes to bed at night, and we get rapid eye movement sleep, right? What happens in rapid eye movement sleep? We close our eyes, we go to bed, and our eyes go. And so they're wiggling, and you've got this abrasive force that's just causing all kinds of damage to that tissue. So this is no good, no bueno. I speak Spanish. So did that answer your question, sir?
Yeah.
Go ahead.
Yeah, I had to nip and tuck to solve that.
And how did it work out for you? Good. Did you have it locally, or did you have it down in Seattle or Anchorage? Or? Anchorage. Yeah. Yeah, they have some good surgeons down there. I happen to use one in Seattle that I've had a lot of success with, but I have seen some stuff from Anchorage, and they do some really nice work. Locally, Dr. Johnson and Dr. Fuller do a little bit of this, depending on what their comfort level is. So that's another option.
Can you do exercises to prevent all this?
No.
There's no eye exercise?
No, that muscle is, it's smooth muscle. So eye exercises are great for strengthening the extraocular muscles, but for all the muscles that are in the kind of adnexa area, they're smooth muscles. It is what it is. So they don't get to be stronger, faster, quicker. All right. And ophthalmos. You guys have all seen this. Movement of the eye posteriorly backwards, okay? May be caused by normal atrophy of the orbital fat. So what does that mean? So if you did a cross-section of my skull right here, you've got the skull, obviously. You've got the orbit, the bone that surrounds it, right? And in that orbit, you've got the muscles and the arteries and all that kind of fun stuff. You also have this fat that's in there. And that fat works as a cushion. It's a protective component to the eye, right? From trauma and that kind of stuff. So you've got this fat that's in there that the eye kind of sits comfy in, and that fat with age sometimes can atrophy. I think it goes right to the belly, but that's my personal theory. So as that atrophies and it pulls back, that eye will start to kind of sink back into the skull. And normally you don't do much about that. I will say these kind of heads up though. It can be caused by normal atrophy of the orbital fat, like I said, or something more serious, such as orbital mass, sinus issues, and for women with a history of breast cancer, women pay attention if you've had breast cancer, fibrosis and scarring from the metastatic breast cancer. So if that breast cancer has spread, potentially it can scar some of that tissue that's in there that's normal, not the fat, but the normal muscles and ligaments in there, and it can cause them to fibrose and pull back. It just kind of sucks it right back in there. So just be aware of that. Need to get this looked at. I think that's fairly obvious. If you have a history of breast cancer and this is occurring to you, please get that looked at.
What can be done about it if you do get it looked at?
Usually if it's just a normal atrophy of the orbital fat, nothing. If it gets bad enough where it starts to affect your eye's ability to go up, down, left, right, all kind of stuff, or if it's from one of these other more kind of scary reasons, etiologies, they can rebuild that, but that's a pretty aggressive procedure, so it's not something that we would take lightly. I can think of one time in my career that I've actually sent somebody down, again, to my oculoplastics and so to have that done, and it was from a mass that was back that had to be removed, which then caused the eye to really sink in there and then to build it back up. So, all right, are we running on time? You're doing all right. Here's the one we've all come for, right? Crystalline lens changes. I'm going to go back to our anatomy. Crystalline lens, right there, okay? So cataracts, clouding of the lens of the eye. I'm going to give you, and my patients who are here tonight have seen this before. This is my cataract. You ready? That's it. That's what a cataract is. It is a clouding of the lens of that eye. And as that lens loses its clarity, and it happens usually slowly over time, but as it loses its clarity, then along with that comes poor vision and poor lighting, nighttime glare, difficulty seeing, even in relatively good lighting, blurred vision, all that kind of fun stuff, okay? Now, if you look at my daughter, for example, back here, a little spark for like, her eye is clear, right? You look at her lens, and it's just as clear as my glasses are right now. So she could, I digress, she could walk in this room, turn the lights off, and still see every one of us, whereas the rest of us be fumbling around trying to find the exit. So it's amazing, but that happens over a period of years and years and years, so we just don't really notice it, generally speaking, until you hit some threshold, some line in the sand that makes you go, I'm really struggling here. I need to get this checked out. Okay. Happens to everyone at some point in our life. And I know we've all had this. My mother lived to be 117 and never had cataracts. She had them. She just didn't get them fixed. All right? We all get them at some point. The question is, at what point do they become visually significant? And visually significant is a very subjective term. Visually significant means that it is affecting your quality of life to such a point that you no longer are 20 happy. Not 2020, not 2030, not 2040, but you are now 20 unhappy. You can't do what you want to do. I used to love to sew. I used to love to read books. I used to love to fill in the blank, whatever it is, but now I don't do that anymore. Well, why not? Well, because it's hard for me. I get headaches. I don't see very well. I struggle. Well, if we can do something about that, why wouldn't we? And I'm telling you this from a guy who sees this every week and makes recommendations every week for cataract surgery. I know sometimes we hear cataract surgery and I think, oh, I don't want anybody cutting my eye. Yes? No. Oh, sorry. You know, you hear cataract surgery, I don't want anybody cutting my eye. It is the safest, non-elective, i.e. cosmetic surgery that we have available out there. The surgeons we have in town here and in Anchorage and Seattle, and the surgical techniques they use are amazing. You know, nothing's guaranteed, but it's pretty impressive. So oftentimes,
If you have cataracts, do they do both eyes at the same time?
depends on what surgeon you go to. Everybody's got their own protocol. Some surgeons will do one eye one day and another eye a week or 2 weeks later. Some surgeons do one eye, do the other eye years later if it doesn't need it as much. Some surgeons will do one eye one day, the other eye the next day.
And will it change your vision in 2040 or 2020? Or?
Theoretically, if the rest of the anatomy of the eye is healthy, cornea is clear, no macular degeneration, nothing else going on back in the retina, and the only thing limiting your vision is a cataract, then yeah, absolutely. The kicker is you've got to make a decision on how you want to see afterwards. Because when they pull that implant out, that lens out, they can put whatever prescription they want back in, right? They can just read my glasses and go, I like that prescription, put that in my eye. It's like LASIK, but it's occurring at the level of the lens, which is pretty cool, except for you can't focus at near if you decide to go for distance, and if you go for near, you can't focus at distance. Now, they do have some multifocal implants that are coming along, and there's one that's actually come out in the last 3 to 5 years that I really like, and they're using it locally here, but I think they're going to get better. And that is going to be really cool, to be able to potentially see at both near and distance without glasses or any corrective lenses. And this is a guy who wears glasses. I'm just as excited as everybody else is. That's coming down the pipeline. You know, it's here on some level, but I think it's going to get better. It's coming down the pipeline.
And they do like contacts, one near, one far?
They can. Yeah. In fact, a lot of patients will say, I want to do that. And what we do with contact, if they've worn contacts for years in that manner, then it's pretty easy. Yeah, sure, let's go get it done. If they haven't, what we'll do is we'll trial that in contact lenses to simulate what their vision is going to be like and just see how their brain adapts to it.
What about astigmatism?
Yeah, they can correct for astigmatism, absolutely. Let's go here first.
I had mine changed for a narrow angle condition. Can
Yep.
you speak about that?
So that is, so for narrow angle glaucoma, and again, there's a myriad of different types of glaucoma, but for narrow angle glaucoma, so in narrow angle glaucoma, we talked about the ciliary body producing fluid rolling around here and exiting right here. There's an angle here, right? You can kind of appreciate that. If I were to squeeze that angle and make it much more narrow, then what would happen is it would be harder for fluid to exit that area right there. One of the definitive ways to correct that is to pull out this lens, which by the time you get a cataract, that lens is swollen, right? It's larger. And so they pull out this cataract and they put in this little bitty skinny implant, which causes this to move posteriorly, which opens up that angle. And they can poke holes in it too if they want to.
Are you going to speak about the damage from overpressure and such?
Yeah, glaucoma was on the list for sure. Yep.
If someone has had cataract surgery and is very unhappy with the results of the surgery, can it be repeated and the problem taken care of?
Potentially.
Potentially.
Yeah, that's kind of a tricky area. Yes, if for example, you have a patient, and for whatever, and you guys need to talk to your surgeons about this. Talk about what you expect after the surgery. If you've been a -2 your entire life, if you've been one of those people that your entire life, you can take your glasses off and always see right here. You may have bifocals because it's more convenient than doing this all the time, but you can always see here, and you like that, and that's fantastic. And you start to develop cataracts, and your surgeon says, hey, I can give you 20/15 vision at distance. This is gonna be spectacular. And you go, great. And you get it, and you go, that's great. Oh, crud. They've taken away your myopia. They've taken away that 2 diopters that you're used to, you've had your entire life. And that patient could potentially be pretty upset. That's a very fixable thing. They just need to go in and pull that lens out and put another one in.
And what if it has to do with the magnification of the starbursts and the auras that you see?
So it depends on the type of lens they used. So different surgeons use different lenses. And if there's a particular lens, if they use a multifocal lens, for example, and that those auras and starbursts are driving you nuts, then yes, they should be able to. Now again, I am not a surgeon, let's make that very clear. So I couldn't speak to a specific case, but I can speak in generalities, and I've seen surgeons do that. They put a multifocal lens in, and there was a certain expectation, which, let's get clear, expectation. You guys need to have that conversation with both your referring provider, whether it be your optometrist or whoever, and your surgeon. Have those conversations. So surgeons get going a million miles an hour, God bless them, because they're seeing 806 people a day, and they sometimes get ahead of themselves. Slow them down, have that conversation with them. All right? If you don't feel satisfied with that conversation, then go back to your referring provider and have that conversation with them. But you have to have your expectations in line with what reality likely is going to be. If you say, I want to have cataract surgery and never wear glasses again, I'm probably going to smile at you. Okay? So.
I thought I heard you say something about you could correct astigmatism.
Correct.
Is that a complex and expensive?
The lens implant is more expensive. So Medicare covers the majority of, and again, I'm not a billing expert, so I'm going to speak to what I know. Medicare covers the majority of a standard lens, standard single focus lens. A toric or astigmatism correcting lens is a more expensive fancy lens, so there's an upcharge there. So I don't know, some surgeons charge $1,500, some charge $3,000, but yes, there's generally speaking an added fee that goes along with that to get that more expensive lens. The procedure itself isn't changed terribly.
I just had a comment. My mom was told by her eye doctor about getting the surgery for cataracts that she could wait, she could wait, she could wait. They told that to her till she was 81 years old, and she died not able to see needlessly.
No,
So I just wanted to pass that on in terms of my eye doctor said I could have it now,
Yeah.
and I don't feel like I'm that bad.
And I think that's an excellent point. I think traditionally we're thinking about the surgical technique they used 30 years ago, where they'd stick their foot in your chest with a fish hook and pull that thing out of there and hope that they didn't damage too much. Nowadays, the procedure is so minimally invasive that there's no reason to suffer needlessly.
She did get to the point she couldn't have any surgery.
Right, she'd gone too far. So she was probably 20 unhappy over here, but they just pushed it off for whatever reason. And so that's that 20 unhappy. That's that. This is affecting the quality of my life. If it's affecting the quality of your life, and we can document that, let's go get surgery with the right expectations.
So how does this toric lens fix this thing?
So think about this. If I had a basketball, I got this up here good. If I had a basketball, cut it in half. It's a perfect half of a sphere, right? If I were to snap that onto the front surface of your eye, and that was now your cornea, you would have a sphere, or half of a sphere. So no matter what direction light hit that from, it's going to bend it the same. Does that make sense? Now let's just say I took a football, and lengthwise I cut that in half, and I stuck that on the front of your eye. All right? That football has a longer, flatter meridian to it, and a shorter, steeper meridian. Does that make sense? So if light hits it in the shorter, steeper meridian, it gets bent more quickly. Okay? If it hits it in the flatter meridian, it gets bent over a longer period of time. So you have two focal points that occur in your eye. That's technically what astigmatism is. So I might have one focal point here where the V's at, and one where the Y is at, and that difference is called the interval of Stern, but that's what astigmatism is. I have two focal points. So my glasses, if my eye is shaped like this, I'm going to get glasses that are shaped the exact opposite of that. I can't do it with my hands, but the exact opposite to offset that. They do the same thing in a lens. They just find out what your shape is, wherever it's at, and they put a lens in to do the exact opposite. So if your steeper meridian's here, they're going to put a flatter meridian in the implant. If your flatter meridian's here, they're going to put a steeper meridian to offset that. Does that make sense? You had a question?
Yeah, I guess I got talked into a symphony lens because I was told I didn't have to choose near or far. I could go both near and far. Didn't work. And at the same time, I guess it had to be adjusted. In addition to full coverage, I had to pay a lot of the partial.
Yeah.
the surgeon was distracted, talks a lot. Known for it. And so when I came out, I didn't get what I was promised. So I didn't get, my bad eye sees far better.
So,
Is that?
and it's not common, but it happens, unfortunately. The symphony lens that he's talking about is that multifocal. I said that if I had to choose a multifocal, that'd be the one I'd pick. So it's a good lens. That wasn't the problem. It was probably one, expectations. The fact they said you can see both near and far, you don't have to choose, I never tell patients that. If it decreases your dependence on glasses, we've achieved what we want, right? If it's decreased your need for glasses, that's a win in my book. But I will never tell a patient, and my patients who are in here, you tell me if I'm wrong, I will never tell a patient you'll never need glasses. So that's that expectation. So expectations are here, reality was here, right? If expectations here and reality is here, then it's a successful surgery. Does that kind of make sense?
Yep.
So that's how I'd approach it. Again, I don't know your situation, but that's kind of what my answer to that would be. Yes?
Astigmatism, is that what causes the tired eye?
Tired eye is caused by a whole bevy of different things. Dryness is a big one, fatigue. Astigmatism, uncorrected, can come into play there. Any uncorrected refractive error, anything that makes it so you don't see as sharp, then your eye's working harder, and more importantly, it's the brain that works harder, right? Because you don't need, if I had a stop sign up here, if it was red in an octagon, it said S and P, I don't need to see a T and an O to read stop. Your brain fills that in. It's blur interpretation. Same with the eye. If I look at this screen, if I take my glasses off, I don't see as well, but I can still make out most of this. I've seen the word conjunctiva enough, I can figure it out. But my brain's working to make that happen. Versus if I go this, it's just clean and easy, and I can just move on to the next one. I'm starting to run out of time here a little bit, so I'm going to scooch forward if that's okay, because I've got a couple other subjects. One more, yes, ma'am.
Just a quick question here. Is this a surgery that needs to be repeated during your lifetime?
No, and that's actually a good question. Let me address that quick. It should be a one-time procedure for initial cataract surgery in the absence of something that went wrong and needs to be repeated, but it should be a one-time thing. What can occur is on the implant, you can get what's called a posterior capsular opacification, which again makes us sound really smart. Basically, it's a little scar tissue that forms on that implant they put in there, and they can take a laser and zip that thing off in 45 seconds, and away we go. So it's been traditionally called a secondary cataract. It's not really a cataract. It's just a membrane that's formed in this implant, which gives us a lot of the same visual symptoms as the initial cataract. Go ahead.
When you look at the eyes of someone who's had cataract surgery, they have a very unique look.
The glint.
What caused, I was going to say cyborg, but.
Yeah, it's reflection off the lens.
Okay.
Yeah, it's reflection. You've gone from this natural kind of muted tissue in there to this glass. And you're just like my glasses, you're just catching the glint off that. Yeah, people give you the double look. Right. It's the glint in your eye is what it is. All right, I'm going to scooch forward here. Covered that, cataracts, cloudy, okay. Presbyopia, Latin for old man eyes. How unoriginal is that, right? But that's always fun. You get a 45-year-old, hey, you have presbyopia. What's that? Well, old man eyes. I'm out of here. Inability of the lens to change shape and focus at near. So again, let me just cover this real quick because I'm kind of running behind. But on how this works is I've got the ciliary body, which is a circular annular muscle. Just think 3D for a second, right? And I've got these little zonules, those little white things that you see up there. These bad boys right here. And they're connected to this lens, okay? And that muscle can contract and expand. And as it does that, it releases tension on those zonules, which causes that lens, which is very flexible, to change shape. Over time, what happens is not that the muscle goes south on us, because the muscle is smooth muscle. It works the same. It's not like skeletal muscle you can work out. It works the same. But that lens starts to lose its pliability, starts to lose its flexibility. Okay? So now this muscle's still working, but this lens is going, not going to do it. It doesn't change shape anymore. I could, kind of like this. If I were to push my kid's bike, I could push it very easily. If I had a parked car in the parking lot, I could put that same force into pushing it, and it's not going anywhere. Does that make sense? So in kids, it's like pushing that bike. In adults, it's like pushing that car. So that muscle's still doing this, because people always get worried, wow, if I wear the glasses, I'm going to weaken my eyes. You won't weaken your eyes. You won't make them better. You won't make them worse. You're not going to make them stronger. All the glasses do is create clear vision, all right? And if you're okay without that, great. I'm okay with that too. If you're 20 happy, that's good by me. But at the end of the day, the glasses don't magically make your eyes better or worse. They just address visual blur. You cannot strengthen this ciliary muscle any more than you can strengthen your intestinal muscle, which is also a smooth muscle. Presbyopia, pupillary changes. This is another good one. So this causes the pupil to become smaller and slower to react in changing lights. That's that you walk, out of Fred Meyer's, and it takes because it's bright in there, and it takes forever for your eyes to adjust. You walk out of the movie theaters. Again, these guys in the back can do it, and boom, their pupils just go. Whereas for us, it takes longer and longer and longer to do that. That also causes objects to appear dimmer, and it makes night driving more difficult. And now you've got this tear film, which isn't working very well. I've got this pupil, which is sluggish to react, and it's actually, we call it senile meiosis. You get this tiny little pupil in there, which doesn't allow light in when you're night driving, and I've got this cataract. So you can see how night driving up here can be a real challenge for a lot of people. That's a good question. Do yellow lenses help? People like the shooting lenses. Some patients say yes, some patients say no. I think that's subjective. All they're doing is they're filtering out one particular light wavelength, because all that light that comes in, all these different colors, they're not all getting focused exactly on the macula because they have different wavelengths. They're all getting kind of focused within this certain area of the macula. And you ever heard of the pinhole effect, where you can kind of do this and take your glasses off and things get sharp? So what that does is it takes all that aberrant light and allows you straight light to focus right on that macula. That yellow lens kind of does the same thing. It takes this certain number of wavelengths that are in there and it eliminates a couple of them and giving us the appearance of better clarity at night. I have some patients who swear by it. I have some patients who say no. I am completely ambiguous. No. It's all up to that individual. If someone told me I sacrifice a chicken and it makes me see better, I'd say go to KFC and get chickens. Honestly, it's all between the ears, right? If that's what it takes, that's what it takes. I'm good with that. Don't sacrifice chickens. I didn't say that. Okay. Vitreous. Okay. A breakdown in the collagen fibers and hyaluronic acid that makes up a significant portion of the vitreous causes floaters. Okay. So this is kind of convenient. The vitreous is just a fluid in the eye. Okay. And the vitreous helps supply nutrients to certain ocular structures as the eye is developing. As we're in the womb, that eye is developing, that vitreous is helping bring nutrients to these structures, but those structures eventually develop their own vasculature, which bring them the nutrients they need. So eventually the vitreous becomes relatively obsolete, but it's still in there. And then over time, it's made up of this very regular collagen fibers, this hyaluronic acid. It starts to break down. As it breaks down, those collagen fibers start to clump up. And these little clumps, if you get a high contrast situation, a real bluebird day, you might see that floating around there. What you're catching is a shadow. That light comes in, hits that floater, and casts a shadow on your retina. Does that make sense? Just like if I had a flashlight, if this was my retina and it was bad lighting conditions and I did this, you wouldn't see anything. If I had a flashlight and I clicked it on this, it would cast a shadow on this. That's what a floater is. Those are the normal floaters we kind of talked about right there. Now, as this breakdown continues, eventually it leads to the vitreous pulling away from the retina, as you're seeing in this slide right here. See how that vitreous from here to here is pulled away from that retina? So think about it this way. The retina's wrapping paper, okay? It's Christmas. It's sitting back there. The vitreous is Scotch tape, and it lines that entire retina, all that wrapping paper. As that vitreous shrinks with time, and this happens to everybody, as it shrinks, it's going to start to pull away from that retina. As it pulls, we don't have pain receptors back in our retina. We have photoreceptors, our rods and cones, right? As it pulls, it's going to elicit a flashing light, okay? Now, if that Scotch tape comes off that wrapping paper clean, it doesn't tear that wrapping paper, that's a vitreous detachment. We're all going to go through it. The concern we have, and this is back to your point, is if it pulls and it tears that wrapping paper, that's a retinal tear. And I'm going to go more in depth in just a little bit about that. That is our concern. So when you go through and you get these flashing lights, you think, it's not a big deal, and you talk to somebody and they go, oh my gosh, you've got flashing lights, you need to get seen. That's why they say that. There's a real and true concern there. And if I have 10 patients in a given month come in with these symptoms, 9 of them I'm going to say, hey, this is normal. I'll see you back in 4 to 6 weeks to see how this is progressing, but don't worry about it. What I'm looking for is that one person, that one individual that does have a tear. Because if that tear is caught early, we can fix it here in town, and it's a relatively easy fix. If that tear is not caught early, and I'm talking to you men because this is us, right? I'll be fine, I'll buff out, no big deal. So what happens is that tear gets bigger and bigger and bigger and becomes a retinal detachment. And now the retina is actually falling off the choroid. And now you got to go to anchorage. And trust me when I say it's a very expensive, very invasive surgical procedure that if we could avoid that, it'd be best for everybody. All right? What's that? We avoid it by getting checked right away. If you notice flashing lights or a bunch of new floaters, you come get seen. All right? Don't stick your head in the sand. Don't go, it's Friday, I'll get seen Monday, because that 48 hours can make a difference. And if you want to see an eye doctor get excited, tell them, I've got flashing lights. What should I do? All right? You're going to see us go, come in, please. You know, because it could be something, it could be nothing. All right, so there's detached vitreous. All right, now we're going to go through the abnormal ocular changes. And again, I've just selected a few of these out here. This isn't an exhaustive list. So if there's something you guys want to talk about, please let me know. Otherwise, I got to wrap this thing up in a little bit here. Okay, basal cell carcinoma. Most common cancer affecting humans. These are relatively slow growing. 75% are found in the face, especially in the nose and around the eyes. Right here is very common. It's relatively benign in most cases, but still needs to be addressed if found. What you'll notice about this one is you see how it's got a little bit of elevation right around here? And that ulcerated center, I kind of think about it like a volcano is what it looks like to me, this dormant volcano. This kind of pearly, waxy edge to it right there. So if you see that, if you're talking to somebody and you see that, have them go get it checked out. We've got excellent dermatologists here in town. They do a good job with it. We've got excellent ophthalmologists here in town. They do a good job with it. Come see me. I'm happy to weigh in on it, but get that checked out. All right? And this is the much more dangerous cousin, the squamous cell carcinoma. Second most common malignant being the key word here, neoplasm of the eyelid. Prognosis is good if caught early. And I'm going to say that about most anything in the eye. I don't care if it's macular degeneration, well, okay, within reason. Glaucoma, retinal tears, most of these things can be addressed if they're caught early. It's when we stick our head in the sand and just say, oh, I'll worry about that later. That's when we get burned. That's when things go south on us. This one's a little different, keratinized, kind of that rough skin looking right there, right? A little more erythema, a little more redness around there. Margins are a little more blended in, and it's got that raised look to it. There's not that center ulceration like you saw in the basal cell.
That's about where your glasses sit sometimes. So how do you?
That's a great question. So generally speaking, if it's from your nose pads, it'll be flat, and it'll just kind of push on there. Sometimes, though, this is how we find these things, is people put their glasses on, and it irritates this. And they go, hey, this is irritated. And you go, oh, well, there's a reason it's irritated. And that's because we've now discovered it's a basal or squamous cell carcinoma. Retinal tears and detachments. So again, this is the cross-section I was showing you right here. This little, see that little tear right there? That little tear happened a significant amount of time before this detachment occurred. You see the detachment all the way around here? Think about that like just that retina's just falling off. Just like you're seeing up here. It's just falling forward. But that little tear happened, and this detachment might not have occurred till a day or 2 or 3 later. If this patient comes in on day 1 when this tear occurs, and they go, hey, I was driving, and I thought there was a lightning storm, or I saw all these flashing lights, or I got this new floater, and we look back there, and we find that, and we can make a referral very quickly, and they take this little laser, and it's kind of cool, I call it spot welding, but basically they just spot weld all around this thing, which is minimally invasive and relatively not very painful, but it keeps that retina from falling off, okay? And you can do that right here in town. And again, we've got excellent surgeons that can do that. Where things go south is you wait and this occurs. This is going to anchorage. This is going to get a buckle, and that literally a buckle, they wrap it around the eye. They shove an air bubble in the eye, and that air bubble expands, which pushes that retina back on there. It's kind of like taking a broken stick and putting glue on it and putting it in a vise. It's got to hold it in place for a while before it sets up. So that's what that air bubble does. And then they got to laser it back down. And again, we've got phenomenal retinal surgeons in Anchorage. But if we could avoid using them as much as I like those guys, that would be really nice.
Do you have to drive or can you fly?
You have to drive. Well, I shouldn't say. You can fly down, but you got to drive back because that bubble can expand, right? If that bubble expands, that's no good. So, good question. But you come in on Friday at 5 o'clock, I get on the phone, I talk to the retina guys, they're going to be in Anchorage at 8 o'clock Saturday morning waiting for you to knock on their front door because this is going to happen.
How long can you not fly?
Usually it's about 2 to 3 weeks.
And what if you see one flash?
Have you seen? I mean, call me chicken, but one flash could be that.
So what are the flashes like? Are they just like a little pinprick or a...
People often describe them as a lightning flash. Has anyone ever here experienced that? So what did...
I had a partial detachment of the vitreous.
Okay.
And I was checked and I was going on a trip and they said, if this happens, wherever you are, you call an ophthalmologist and you say, this has gotten worse and they'll get you right in.
Yep, for sure. Like I said, you want to see an eye doctor, get excited.
And it just, it did
And,
time to time.
yeah, and so what happens is that vitreous slowly detaches and pulls off. That scotch tape eventually pulls off completely, and then there's no tractional force. There's nothing stuck to it. But what was the flashing light like?
The flash was, for me, it was a long white thing on kind of up to the side.
And it was quick?
Yeah, it was quick, and I noticed it most often I'm waking up, I think.
Yep.
Or in the...
Because you're laying down, and all of a sudden you change positions, and that vitreous sloshes forward and tugs.
Mine was suddenly, and it was like streaks of multiple colors through the edge of my visual field.
And it's not... Yeah, and it'll come and go though, right? It's not just one consistent light. It's like a flashlight in the eye. It's just kind of thing. Usually, it was all over the place. And again, it depends on what the extent of the vitreous pulling on it too. Some people have very dramatic experiences. Some people have very subtle experiences. So to answer your question, one flash of light, I'm gonna tell you come in. If you don't, then at least that's a risk you have to take. Okay. Glaucoma. We asked about that. So there's a bunch of different types of glaucoma. I'm just going to go over the basics one, which is we call open angle or glaucoma. So glaucoma basically is death of the optic nerve, if we're just going to boil it down to what it is. And again, remember the visual pathway. Light comes in, macula, nerve starts to die slowly with time. If that nerve is dying, it's kind of like a coaxial cord between your computer and your monitor right here. If that nerve dies, that information doesn't get sent back to your brain. So then you get depixelated. You get areas of your visual world that just are blacked out, okay? And it generally starts like this and works its way in. And I have patients say, I'm still 20/20. I said, yeah, but it's kind of like looking at the world through a toilet paper roll. No one wants to do that, you know? So one of the leading causes of blindness for those over the age of 60, I thought that'd be appropriate. There are several different types of glaucoma, often referred to as the thief in the night. The thief in the night because we don't know it until it's come and robbed our vision. You know, if someone comes into my clinic and says, I can't see over here, and I suspect glaucoma, they're 50% of their ganglion cell layer is gone. They're in advanced glaucoma right from the get-go. Our goal is to catch it early on. Our goal is to catch it before you notice any symptoms. You come to me and you think, I'm just getting my eyes checked, and I go, okay, oh, you've got glaucoma, and you go, I don't have any problems. I don't know what you're talking about. And I say, that's a good thing. Let's not develop problems, right? Let's treat this because it's very treatable, and let's fix this before problems develop. This is a reason you need regular eye exams. If for no other reason, let's say you say, I see great, my tear film is fantastic, I don't have cataracts, my eyes are spectacular, fine, great, wonderful. This is a reason you need regular eye exams right here. My rule of thumb is if you're over the age of 50, once a year.
At many of the health fairs, there is someone who does what they call a glaucoma check. Is that enough with just that little air pressure to the eye?
I'm going to say no.
Okay.
Because there's lots of patients who have normal tension glaucoma. So again, if I just give you a quick, it's 8 o'clock. If you guys want to go, that's fine. Or I'm going to wrap it up here in 5 minutes. Do you want me to keep going or? Okay. Just give me 1 second. Let me finish this thought before you jump on this. So again, glaucoma. So you've got this pressure that builds up in the eye, right? And it's compressing the blood vessels in the back of the eye, right here. And again, this is the theory of glaucoma. So it pushes on these blood vessels. Well, if you push on a blood vessel, you slow the perfusion of blood to that vessel. If you slow the perfusion of blood or the flow of blood through a vessel, then the tissue that was being supplied with that blood gets less nutrients than it needs, and that tissue slowly dies over time. If I took a rubber band and wrapped it around my finger real tight, I cut off the blood supply, that's going to die. And that's a much quicker process. This is much more insidious, much slower, right? So when you have that, part of the thought is if there's too much pressure, it's just pushing on a blood vessel. Some people have very weak blood vessels. So normal pressure still compresses that blood vessel enough to slow that perfusion. So you come in here, we get air puffed, and you go, oh, you have 19 millimeters of mercury in your intraocular pressure, you're fine. But really, your blood vessel walls are very weak. Or you were hypertensive, and now you're hypotensive because you're on some kind of a hypertensive medication, and it brings your blood pressure down to 110/60. Well, now that blood vessel has a lot less pressure, internal pressure in it, right, because your blood pressure is so low. So that 19 pressure, which normally wouldn't get affected by 130/90, gets affected by 110/60. Does that make sense? Yeah, so that's the long answer. I could have shortened that up. But yes, no, I don't think that's adequate, in my humble opinion.
When the fluid flow is blocked in the eyeball, say from narrow angle, part of the glaucoma condition, could you speak on the pain caused by that, the initial symptom?
Yeah. So this is a very specific type of glaucoma. This isn't age-related. This is just more glaucoma in general. But when your pressure, again, if I could, so the fluid comes, oh, there it is right there. Fluid comes out through the ciliary body, wraps around here, goes into the trabecular meshwork. And this particular one, you can see how narrow that angle is right there. It's actually blocked. So you get this pressure that builds up, builds up, builds up, builds up. And it gets above 40 to 50 millimeters of mercury. And now it causes this congestion, this venous congestion in the eye. It causes this achy, painful eye that looks red. You get this mid-dilated pupil. This pupil's kind of stuck because it's got all this pressure in there so that those muscles in the iris can't contract and expand like they normally do. And then also the cornea gets steamy. Remember we talked about the endothelial cells, the pumps at work? Well, if you got a bunch of pressure pushing on these pumps, they don't work like they should. Or if there's too much pressure there, they don't work like they should. So you get this painful, steamy, and sometimes nausea. People report vomiting. Here's the tricky part of this. And again, this isn't age-related. If you've had your eyes examined, someone should tell you if your angles are narrow or not. But here's the tricky part of this, is that oftentimes this happens and people go, oh, I'm going to go to urgent care. And I'm not picking on urgent care. They do a fantastic job. But they go to urgent care or a clinic that's not realizing that their angles are narrow and their pressure's high, and they look at this eye that's kind of red and steamy, and they go, oh, you've got conjunctivitis, you've got pink eye. Here's some Vigamox. Take 3 drops 3 times a day, and if it's not better in 24 to 48 hours, go see your eye doctor. Okay? So we've got excellent emergent care here in town. We've got very good urgent care here in town. But I'm telling you, if you've been told you have narrow angles, you need to keep that up here. So if this ever occurs to you, where you get this red eye, you need to know, okay, is this really pink eye or is there something else going on here? Did that answer your question? Okay. It certainly can. Yes, damage to, death of the optic nerve.
What's the treatment?
For normal glaucoma or for normal glaucoma? Eye drops. It's very treatable. Eye drops, which cause, we think about this like a sink. If that's the faucet and that's the drain, the eye drops decrease the amount of fluid produced by the ciliary body, turns the sink down. Sound effects are part of it. And then it opens up that drainage system. Little draino opens that up. So now I got less fluid being produced, more fluid being drained out. Pressure inherently drops, alleviates the pressure, the compression on that blood vessel. Blood reperfuses. Everybody's happy.
So lumigrene is a common chemical.
I got 3 different ones. So go ahead.
Lumigrene is a common chemical.
Yeah, Lumigan is a prostaglandin analog. It's an excellent drug. Love it. It's also good for eyelashes for the ladies that want to grow them out. That's the Latisse that you see. Oh, sorry, I missed it.
Different question from before. A few years ago, I was at a guitar camp way out in the woods, and I had a series of these sudden flashes that after a while they just sort of stopped. And I've had eye exams since then. But should I be worried about that?
So, excellent question. What you likely experience is what's called an ocular or ophthalmic migraine. And what that is a variant of a normal migraine. You get these visual...
It's not the same thing. I have ocular migraine.
Okay.
These were just flashes, light flashes.
So that may have been the vitreous detaching. If you've had an exam since then, which I'm pretty sure you have, but if you've had an exam since then and your retina has been looked at, then it's safe to say that you're in the clear. Does that make sense? If there was a tear, then hopefully whoever your provider was would have found it. If not, I'm in trouble. All right, I'm going to move on. We're in the home stretch. This is the other big one, age-related macular degeneration. I'm going to go real quick through this. One of the leading causes of vision loss in those over 50, it is damage to the macular tissue. And remember that light that gets focused in the eye all gets sent to the macula for the most part. So, whereas glaucoma is peripheral, macula stuff is all central, which may be slow and insidious or progress somewhat quickly, often associated with blurred vision, specifically central vision, distortion of the central vision. And again, distortion is my door frame I talked about. Anything that should be straight, if it's got a little wiggle to it, that's not good. And patches of vision loss. Risk factors include smoking. If you are a smoker, please stop. It's that simple. Poor diet and health, family history and genetics, and hypertension. Apparently I got really into this one. Treatment, yes. So treatment. For dry and early intermediate stages, there's no real treatment. If we don't do anything, we just watch it. That being said, multivitamins, particularly lutein and zeaxanthin, are very important for those patients that have dry macular degeneration. They're important for all of us. My personal opinion is we should all be taking it, right? They have done studies where you take a cadaver, someone who died and had macular degeneration, and someone who did not have macular degeneration, and they studied the lutein content, and the people who do not have it have a much higher density of lutein in their macula. Ergo, lutein's good for the macula. We think it's an antioxidant, not sure exactly, but lutein's good for the macula. There was a study done some number of years ago called the Age-Related Eye Disease Study, AREDS. Based out of AREDS, we found that lutein, omega-3s, vitamin C, E, a couple other things in there. I should know this, but anyways, that these are all good for the eye. You've seen them branded in the stores, Ocuvite, PreserVision. They base all of that on that formula. My personal recommendation is that while that's great, I think they're under lutein in that formula because they have to base it on the ARED study, right? There's other supplements out there that just lutein you can buy at Costco that are 25 milligrams and have zeaxanthin in it. I think that's better. So I'm a big fan of that. Omega-3s. Good for the brain, good for the joints, good for everything, you know?
Have you ever heard of a stuff called MacuShield?
MacuShield. No, but I can almost promise you that it is some version of that ARED study. Yeah. And again, there's a lot of stuff out there. If it says AREDs on it, it has to be a specific formula. But it also has to be, generally my findings, very expensive. Unless you just have a tree in the background that makes money, which if you do, talk to me after the lecture. But otherwise, just go get the generic. Go get the often. Lutein's a big one I always recommend. And like I said, I like omega-3s. A, C, and E are good too, vitamins A, C, and E, but you're probably getting that in your normal diet. Kale's great.
You talked about the flashes. Is there a way, if you go get your eyes checked, if you have that they can tell that possibly it's been like an ischemic stroke or something?
Yeah, that's a great question. Absolutely. Yeah, you'll see. If it's obvious enough to induce flashing lights, then generally speaking, that you can look back there and see this atrophied area, this blood vessel that's kind of scrawny, kind of skinny, and you see this big white area around it where it's become ischemic, the tissue's become ischemic. So that's a very real possibility. Moving on, conversion. Okay, so, sorry. I don't know how I can do this. Sorry, I butchered it. So I'm going to move on to wet. So why do I bring you in every 6 months or every year when you've got dry macular degeneration and I just got done telling you I can't treat you? I can't help you. Well, Dr. Mavencamp, why do you need to see me? What I'm looking for is conversion from dry to wet. dry, blood, wet, okay? What happens with wet macular degeneration is as that tissue dies, that tissue sends out a signal. It says, hey, we need help. We're dying here. So the body, in its infinite wisdom, says, hey, I'll get you some help. I'm going to grow some new blood vessels in there, neovascularization, new blood vessels. So these new blood vessels start to grow in there. They're all convoluted and scrawny and kind of weak, but they rupture very easily. All right? As they rupture, they leak blood into the retina, which is a compartmental space. It's not designed to have fluid in it. So it's got a bunch of blood now, and that causes that retina to separate. And then that blood spills out into the actual retina itself. So how do we treat that? 3 things. Firstly is ocular injections, which sound awful, but if it saves your vision, well worth it. It's an anti-angiogenic drug. Angiogenesis is the process of causing neovascularization, so it tries to stop that signal from being released and those blood vessels in withdraw. 30 years ago, you converted to wet, we might just go, hey, go get books on tape, good luck. Now we've got avascular ocular injections, which is fantastic. I'm sorry, go ahead.
So explain again how the lutein helps with this.
It's an antioxidant. So if the thought is there's free radicals that are being formed here that aren't being carried away from my blood supply and they build up, I kind of think about it like a trash truck. If I've got a trash bag I put in my yard every Monday and the trash truck comes and grabs the trash bag and moves away, we're in good shape. If I put out 3 trash bags every Monday and it takes 1 bag, and the next Monday I put 3 bags out and it takes 1 bag, I'm going to get a buildup of trash in that area. It's kind of the same thing. We need the trash trucks to come in there and pull that stuff out of there. And that lutein's an antioxidant. We think that's how it works.
Well, would more sleep help?
I couldn't, yes. I mean, I couldn't honestly tell you that. I don't know that I'm that educated in that particular realm to be able to discuss that. I've never seen any studies in that. That doesn't mean they're not out there, but I haven't read any. But does more sleep help? I've got 3 kids, yes. Absolutely. The last one is after the injections, the photodynamic therapy and laser treatment are the other ones. And then if all else fails, oh, I misspelled it, darn it. If all else fails, there are vision devices and aids that help patients maximize what vision they have left. You've seen these patients. It's a heartbreaker. They come in and they're having a conversation with you, but they're looking to the side, right? Because they're using what little vision they have, and they're struggling. There is stuff out there, magnification aids, computer aids. It's pretty cool now where at least they can read a newspaper. They can maybe watch a show. Maybe they can do something to allow them to still have a somewhat higher quality of life than just going blind. Okay? Last one, and this is a big one, folks. Giant cell arteritis. Not very common, but I want you all to pay attention to this. Most common form of vasculitis that occurs in adults. Almost always occurs in patients over the age of 40 with a mean onset of 72. Occurs in women 2 to 3 times more than men because you have to deal with men. That's my theory. Symptoms include headache, jaw claudication, which is when you're obviously eating, especially after eating, pain in the neck and shoulders, fever, blurred vision, scalp tenderness. We are not entirely sure what the etiology here, what causes it, other than it is the body's immune system attacking and inflaming the arteries. This is a medical emergency. If you have that headache, if you've got the tenderness, if you're eating something and going, God, my jaw is killing me, don't put it off. What did I say right in the beginning? Catch it early. Whatever it is, fill in the blank, catch it early. Okay? Because once your vision's gone from this, it's irreversible. It's gone. When it starts to, those vessels start to flare up and get inflamed and choke off that optic nerve, that's it. That nerve isn't going to regenerate itself. Any questions on this one?
Go to the ER or another eye doctor?
If it's after hours, go to the ER. And if they feel it necessary, they'll call whatever ophthalmologist is on call in to take a look at it. Absolutely. If they're not sure, sometimes they just start them on 60 milligrams of prednisone, which is not a bad idea, quite frankly, because the alternative is irreversible vision loss versus you get a little bloated on the prednisone and have the side effects and the jitteriness, but at least it's kind of, you're being cautious. We've had kind of a circular Q&A, so if there's any other last minute questions, let me just start here and work my way this way.
Can you touch on sun damage or?
Absolutely. So everything you see here, remember the sun's got ultraviolet rays, right? So they're coming in there. The lens of the eye, the crystalline lens, is this kind of sacrificial anode that helps block out a lot of those ultraviolet rays, which is kind of what induces cataracts, but it can also damage the macula. So as far as macular degeneration is concerned, we should all have some sort of UV protection. Your regular glasses, my glasses, your glasses have UV protection in it, just like your car's windshield does. Right? It doesn't have to be dark. That being said, I recommend sunglasses. Go ahead.
Have you run into neurofibromatosis?
Yeah, NF, 1 or 2.
So what's your suggestion for that? Have you done surgery?
No, I'm not a surgeon, so I have not. I refer punt.
I was hoping you'd say a little bit more about, you said dry eye causes watering.
Okay.
What can you do about that?
Then you've got to reestablish that tear film. Okay? You've got to reestablish the tear film. First thing you got to do is along with the dryness is inflammation. So we use steroids, topical steroids, eye drops, get the inflammation to go away. Then there's Restasis and Xiidra are our prescription eye drops that we use oftentimes, which cause a thickening and increase in volume of the tear film itself. So we thicken that tear film, we reestablish it as being a healthy tear film, which then covers that surface of that eye again, which then stops that watering, stops that cycle, it breaks it. Does that make sense? Now I'm simplifying it. It's not that easy. For some patients it is, some patients it's easy, but that's the goal.
And that's indicated when you just get like tearing in response to stepping out into the cold?
Yep, paper from the happen. Hang on, I'm sorry, I lost my line. Right here.
You started your talk by mentioning LED lighting and the benefits for aging eyes. Could you comment on that specifically, things that people can do in their own homes and relative to the Kelvin scale?
Absolutely. So she talked about the Kelvin scale. So there's white light and there's this kind of yellowy light out there. Some of that's preferential. Like in your garage, you want white lights. You want to get as bright as you can, as a rule of thumb. In the house, maybe not so much, but you still want to get LED lights. There's not one particular warm versus bright that I recommend. I always say there's a fine line. What is it, 3,500 to 5,000? I forget what the range there is exactly. Is that what it is? Because it's high 6. So I don't know what the range there is exactly. I would say go as high as you can handle without getting headaches or eye strain or squintiness. Does that make sense? Because you want enough light for it to do good, but you don't want so much light that you're like, oh, I can see that, but now I'm squinting my eyes. Now I need sunglasses indoors. That doesn't.
Is there potential for eye damage with the higher
No.
Kelvin?
No. The wavelength of light there does not damage the eye, unlike the sun, for example. It's the same as when you come to my office and I shine that super bright light in your eye and everybody goes, God, I hate you. That wavelength, even though it's bright, does not damage the eye. There it was.
Cupping. Explain what that is and what causes it.
Optic nerve. Do I have a good optic nerve picture? Yeah, I think I in the very beginning. Okay, not very good, but so there's the optic nerve. In this healthy optic nerve, it's flat, right? If it was in any belly button and it had a big cup right here, that puts you at increased risk for developing glaucoma. Because if it's cupped, that means there's less tissue here, and where there's tissue is thinner, then potentially it's easier to compress and damage that tissue. Does that make sense? So if you've got a cupped optic nerve, that may just be the way you're put together at the factory. That just may be your anatomical disposition, right? But it does put you at a higher risk for developing glaucoma, especially if there's a family history or your pressure's high or you have some other corresponding comorbidity. In the absence of that, just cupping, depending on how cupped you are, we may do glaucoma testing once every 12 months or 24 months. Yeah.
I'm thinking we should just do 1 or 2 more questions and then formally thank Dr. Mavencamp, and then I'm sure he'd be willing to answer some more after that. So let's just do 1 or 2 more questions.
Can you talk a little about macular films and what the surgeon does to correct that?
Epiretinal membranes, what you're kind of talking about?
They just call it macular film one night.
Okay. So on the macula, you can get this membrane that grows over it. It's called the epimacular membrane or macular film. It's this scar tissue, this fibrous tissue. It used to be called cellophane maculopathy. That just kind of grows over the macula. And as long as it grows smoothly along the contour of the macula, you can see that macula has that little dip in it right there. As long as it grows along that contour, we're fine. But if it grows and then starts to tug, it can start to separate the retina and separate that macula. And then it causes distortion and blurred vision. And if it gets dense enough and thick enough and fibrous enough, they actually have to go in there and tease it apart. And they actually take that film, that membrane, and just kind of, it's kind of cool. They take a little spoon and they hold the retina down and they just peel it off of it.
A comment on the LED lights. If you get too much blue light, it can be hard to go to sleep.
Yeah, that's an excellent point. Yeah, same with our iPhones, you know.
I think we should probably formally thank Dr. Mavencamp. Before we do that, and I'm sure Dr. Mavencamp will answer more questions after.
Sure, if you guys want to get up and leave, you're not going to hurt my feelings one bit.
I'm just curious what took you into this field of medicine?
I didn't want to be a dentist. No, I'm teasing. No, it's a great question. I was going to go into pediatrics, but I spent a month down in San Antonio in the NICU in the pediatric. And it's fun when kids get better, but I'm too soft-hearted when they didn't get better. I didn't handle it very well. So I'm kind of a weenie that way.
The aging aspect of vision.
Yeah. Oh, the specific age. So then once I got away from pediatrics, I was kind of wondering for a little bit, and I actually dated a gal whose dad was an optometrist and followed him around and thought, this is kind of fun. I like this. And that kind of started me on that direction. Hang on one second. Let me just get...
That always gives me such a head notice.
And I think it's because halogen lighting, again, has a lot of diffractive properties to it. LED is more focused. You know, it's more of this, like a clean, if I had a flashlight that had LED, it would have clean edges to it. Halogen has this kind of diffuse lighting to it, and that particular wavelength diffracts light a lot, so it's bouncing around that eye a lot more. And especially since your pupils aren't working like they used to, then it makes it more difficult. I'm sorry, go ahead.
My son is 45, and I know he's been to an optometrist before, and probably 10 years or more when the clinic was in the other place, Fairbanks.
Eye clinic at Fairbanks, yep.
And he doesn't wear glasses. So I'm trying to get him to go back because, well, I have glaucoma. I have had cataract surgery and so forth.
So yeah, no, for sure. If he's over the age of 40 and he has a history of glaucoma, and again, that's you know, everybody says that. Well, I see just fine. Why don't you get seen? Because you don't know what you don't know until you don't know, right? Until you actually go through and find out what's there. You know, he could cruise along, everything's fine, and then the problem is when things go south, and then they go south at the advanced stage and not at level 1. It's like cancer. You catch it at level 1, and you're much more likely to have a better prognosis in the long term versus level 4.
He takes care of his teeth, so I'm thankful for that.
That's good.
After your presentation, you probably won't be able to get in your office for a year and a half.
No. Yes, yeah.
Sometimes in winter, you're driving down the highway and you see greenish lights coming at you or pink or something, and they seem to be more irritating. Are they harder on you?
Are you talking about some of these fancy headlights they have that are supposed to... No, I hate those things. Studies have shown that they do not actually do any better as far as visibility is concerned. Now, if you want to put them on a moose light and you're driving down Chena Hot Springs Road and there's nobody out there and you want to hit them on your high beams, great. I'm all for that. But just for driving around town on your low beams, I think personally that they should be outlawed, but that's just my personal opinion. No, I don't think they improve the vision that much. I don't think they do that much to really improve the ability of the driver to see. But they know it.
For us to see coming at them.
No. But if you have a hard time because of the pupil, then you know, look at the light or look at the line. If you can see it in the summertime, great. In the wintertime, if you just try and pick a line, don't look directly at the light, because once that light hits you, then it temporarily incapacitates your vision. And then you're driving blind for 5 to 7, maybe 10 seconds, and that's a little scary. Yes, you in the back, you have a question? Oh, you want to wave? Hi, Addie. All right, guys. Yes.
Can you tell me the difference between a light flash that you get with an ocular migraine and a detached retina?
For sure. So generally speaking, a detached or torn retina, it's going to be quick. Pop, 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 right? It's happening in a series. And it's coming off there. In an ocular migraine, it starts slow and kind of, generally speaking, it starts slow and kind of builds and then kind of crescendos and then comes back down over a period of usually 5, 10, 15, 20 minutes is the norm. And then it kind of comes back down and people run to your office and go, I just had a stroke. And you go, well, let's talk about this first. But it's more of an extended period, and then this kind of gets better. And it's more of a zigzaggy, like you're looking through a kaleidoscope, oftentimes. Or you get the zigzag, and everybody experiences it a little bit differently, versus this lightning flash.
Does the lightning flash go away as well?
In the retinal tear, you'll notice a bunch early, and then it'll start to subside a little bit. You'll think, oh, it's getting better, it's fine. You still want to get checked out.
So what I had, I just want to say it was like a squid being ejected ink into my eye. And I still have the floaters. It was dark.
On the ophthalmic migraine?
No, the detachment.
Oh, yes, the detachment, yes.
So why, I mean, I haven't heard anybody say anything dark, but that's what it was like. I thought maybe I had coffee around.
So what might have happened, you might have had, that vitreous might have popped out there very hard, and that's a specific type of vitreous detachment called a posterior vitreous detachment. That vitreous comes off there and tears the retina, and then that hunk of vitreous is kind of floating right there, right in your line of sight, and that can dim things up for you a little bit.
I still have
Yeah. And the floater will always be there. Yeah. And there's certain times you're like, oh, I noticed it, sometimes you don't.
Just an oddball. I'm a geologist. Is there anything like a fossil record? And what could it mean?
Is there anything like a fossil record? I guess I'm not clear on that. What's that?
Of eye disease.
Oh, you mean like a...
Could be 1,000,000 years old.
Yeah, you know, I don't know that I could answer that question very well. Is there, yeah, but is there a long-standing history? Yeah, absolutely. Especially you get the British journals. It's amazing how you read some of that stuff, and they knew stuff that, you know, it's incredible. They're describing this in great detail, and you're like, oh, that's Fuchs disease. But they didn't name it Fuchs disease, right? They named it whatever this weird, funky thing is. But there is, going back far enough, there's certainly a lot of diseases that we know about. We just put formal names to them now.
I had a double lens implant years ago, and since then I had no night vision at all. I can't see a thing in the dark. Is that common?
For some patients, you know, I'd say 4 to 7%. You get this photopsia afterwards. Is kind of, and again, how much of that is the pupil coming into play there? Because unfortunately, when they do that surgery, they do have to kind of sometimes pull in that pupil a little bit. Can that damage those fibers so they're not as reactive? Yeah. That's a very real possibility, and it's an unfortunate kind of roll of the dice. It's not the norm, but it's a possibility.
Yeah, it may not be a disadvantage, but have you ever treated anybody for synesthesia?
For what?
Synesthesia, it can affect...
Oh, my daughter has that.
It's sounds have colors, vice versa.
A number has
I have not treated, but I know what you're talking about, yeah.
I'm pretty sure Leonardo da Vinci had it.
Yeah.
That's one of the reasons.
I've never treated anybody for that, but yeah, I know what you're talking about. It's pretty amazing.
So this ocular migraine thing, is it part of the headache syndrome?
So it's the visual aura that you get with a migraine, sans the migraine proper.
Without the headache?
Yeah, exactly right.
Why is it?
Bye, Dr. Jill, thank you.
What causes that?
We think it's a lightning storm in the occipital lobe in the back of the brain. It's this kind of vasoconstriction, dilation of the blood vessels, and you get this kind of electrical storm back there. It's the theory with it. We don't know exactly. All right, guys.
One quick question. Would you think because we're sending up in intensity that we would have less glaucoma here than people with more intraocular lesions?
No, because the glaucoma has nothing to do with UV exposure necessarily. Macular degeneration possibly, but here's a disadvantage of us being up here with macular degeneration. Is not only are we getting it from up there, but in the wintertime we're getting it from the snow coming off there. So you're double whammied. Hey, thanks, guys. Appreciate you coming out.